No, I can hear you now.
Okay. Didn't miss anything. And so I suppose one of the things that I do when you you know, think about somebody that you don't, whose work you don't know terribly well, have a look at their publications and just see what are they interested in. So clearly the interest of technology, and for people with dementia features heavily in publications. The issue of cares for people with dementia features. I was interested that Martin, you talked to this about work he's done in Ghana and various other countries. So a tremendous breadth of experience, and I'm looking forward to hearing about that from you.
Thank you much. That's a very nice, a generous introduction, and I'm thrilled to be back in Galway. So thank you very much for making my trip here so great, and thanks particularly to Eamon for inviting me. Good luck, Eamon, today. Thanks also to Christine for organising it, and the HOMEDEM team on all the students. And I had a good meeting with the students this morning on how to publish. So it's nice to see them come back again, hear me again at the same time. When I was giving a talk a few years ago, the chair said, "Oh well, this is Martin Orrell, and then he'll have all his notes on a post-it." Well, I need a bit more these days for my notes. Technology. I remember my dad, my mum and dad are both passed away now, and my dad, I gave him my old word processor, and he called it his word protester. You had two discs that you put in, you had to program it, and when I offered him the next model up, he said, no, he's fine, he was just fine with this. What he wanted to do was type. I remember my mum also had a mobile phone, and this was quite some time ago, and you couldn't ring her on it because she just put it on when she wanted to make a call. Then she turned it off again, save the battery. So technology's come on a long way, and with things like AI and everything like that, it's like the whole world is opening up. So I'm going to talk about two Marie Curie programs we had, which was kindly funded by the EU. As you'll see, the logo is a bit similar because I quite like the logo for Induct. So we just modify it a bit for distinct, and we were lucky to get these two programs with 30 PhD students across 8 countries, and also working with the interdisciplinary Academy. If you're a PhD student or early career researcher, do think of joining the Academy. I know a lot of you are members already because it's free, but there's things like workshops, there's training, there's traveling scholarships, and there's a whole range of things. And the lead for that's Professor Franz Verhey, and it's shortly to be Sarah Bartel, who's going to be the new chair of the Academy, and she was one of our original PhD students on Induct. And just to thank also our program manager, Ori McDermott. Now, I have a book that I bought for somebody here, which is based on Induct, Improving the Lives of People with Dementia Through Technology. So I'll mention that if people are interested. And Ramsey is going to have the copy. And so here we go. This is the official handing over book. Ramsey, I want you this book. So actually, I'm mentoring Vamsi through the interdem mentordem program, which people have answered. Also, Zayu Wang, who's here, I'm mentoring. So it's been a great opportunity to meet them both here and be able to talk to them in person. I was saying it feels like they're real people when you actually meet them, rather than people on this telly thing. So so I'm very pleased to be here and talk about that. And so this is I'm going to talk about a summary of the programs and why we did them. Now, people are thinking of applying for Marie Curie networks because we got one and then we got the other one a few years later, and we thought, well, we might be able to do it again. And some of the rationale for it was, what's the EU about? The EU is about prosperity. Prosperity is about trade, and trade's also about knowledge exchange. So these programs are about training, finding people from all over the world and training them to PhD standard, and training people that Europe wants to hire for various industry, charity, academic jobs. So basically increasing the capacity of Europe. And I think if you have that in your mind when you're writing one of these programs, I found that very helpful. So, this. I'm trying the various page down methods. I do have more than one slide to show you. Okay.
I have no idea why this works, but it's more often than not those.
Okay, so this was funded by, thank you, Sharon. And this is funded by Horizon 2020, and we had it in the INDAC program. We had very many universities across Europe, Belgium, the Netherlands, Czech Republic, Sweden, and then I put people's faces up here because they work very hard. This is the INDAC PhD students. Can't see the detail, but you can see well, they look happy, don't they? And so based on Induct, we also applied for Distinct. And again, there's most of these people have now got their PhDs, and a lot of them have actually carried on in research, which is exciting that, you know, because you want, in the UK, around 1 in 3 of PhD students stays in academia. But if you have more than that, or people going to related jobs, that's really useful. We had an advisory board from around the world, including Maurice Mulvenner from Ulster University, and from also Steve Zarrett, who is very well known in old age research. And so why are we looking at technology? Well, I mean, it's here to stay. And in some ways, I think COVID accelerated our use of technology and changed the world, and also older people's use of technology as well. And, you know, think about things like Zoom chats. I mean, did it have many Zoom chats or WhatsApp chats before? And now it's taken for granted that some of our meetings will be on Zoom or on Teams. You know, we'll use WhatsApp for lots of different communications. And so COVID is, I think, ramped things forward a few years from where it would have been, because needs must, really. So about 80% of households in the UK over 65 have internet connections. Internet use doubled to 54% in the over 75s into 2020. And it's the most highly used and preferred source of information for people with dementia and the carers. And also some of you may be familiar with online cognitive stimulation therapy. Well, or cognitive stimulation therapy by group. Well, people were rapidly adapting that to an online method, and people were having CST by Zoom because they didn't have any other options. And some of the advantages of having Zoom for things like these groups is actually people can take turns in speaking. You know, you can manage the groups, and you can so everybody can get a chance. They speak, they put their hand up, and actually sometimes in a group of people where somebody perhaps is talking quite a lot, it's quite hard to manage that thing. So there is a lot of advantages, but there's concerns for people who are digitally excluded, and that can be related to not having the tech, not having the training. Sometimes it's you know, poverty and lack of Wi-Fi connections. Sometimes it can be in rural areas, not very good Wi-Fi, so they're now not able to access a range of things. So our task force highlighted need for high quality studies on usability and effectiveness, and also cost effectiveness. And it's key to have involvement with people with dementia. We've been very lucky in our groups, because from the word go, we were working closely with the European Working Group for People with Dementia, which has been, you know, they're very used to research. They're very helpful. They're very good ideas, and we were able to workshop some of our things with them. So technology may help independence and autonomy. There's a poor understanding of how people use it in everyday lives. And I think in the past, a lot of you'd have healthcare researchers using technology and testing it out, and you'd have developers developing technology and saying, use this. But the two didn't get together, and didn't get together with patients and the public to actually involve them in the whole process. And if people don't like something, we all know they just won't use it. So So one of the new approaches is a kind of rapid action where you work with the developer, they develop a piece of technology quickly, it's tested, then you test it again, and you go through a rapid cycle of testing it, rather than giving it to the developer and they come back in 6 months and say, here's what you wanted. So this is very important. So now one of the things about technology is also the stigma around it. People have said, you know, sometimes they had a pendant, which was like an alarm pendant. You fall over, you can press the button in the middle of the pendant, and that calls for help. But actually people say, well, it doesn't look nice. You know, why would you wear something that marks you out as somebody who's got a problem? On the other hand, having something like an Apple Watch or something like that, and if you have a fall, you press the button on that, or having a mobile phone, then you're keeping up with what the technology is. You know, then you're kind of modern and keeping up with technology. So actually, you need to think about the users. And sometimes with some of our work we've done on helping people plan around independent related activities, the difficulty is, do people see that as helping their autonomy and their empowerment, or do they see it as like homework? Oh, you've got to do your homework that you've been set. And so, you know, the things about homework is, well, somebody's got to check it, see how you got on, and it's obligatory. And so it's a question, is it something you can use as a useful tool, or is it something that you feel obliged to use because you're in the research project? And we had a project on an app for cognitive stimulation therapy in dementia. People will know there's quite good evidence for CST in dementia, and this was a one-to-one app designed with people with dementia and with family carers. People liked it, people wanted to use it. What we actually found was, though, in practice, people either went through it quite quickly, or they didn't really do it as often as we expected them to as part of the program. And part of that, I think, was family carers and people with dementia. They didn't see it in the same way as they saw like a prescription. You know, this is a prescription from the doctor you need to use. So they kind of saw it as something which was, you know, kind of add-on to what they were already doing sometimes. So now, in part of the INDUC studies, there was work on how surveillance and safety things are used and how they're used to monitor people. And, you know, this is a bit intrusive, really, isn't it? Being videoed or being monitored. It's not like having like a smoke alarm, which just tells you if there's smoke in the house, but having some kind of, I'll tell you a story. So my mum had dementia, and we got, there was somebody who, there's somebody who needed a place to stay and could you provide a little bit of care and support. And he said, oh, would you like me to install video cameras so you could always, he said, no, because, you know, how would you feel? You know, how would you feel somebody videoing you and watching you, and or with the ability to see where you were? It's very, it's not good for privacy. And a lot of the monitoring equipment marketed for people with dementia, say, they're using the same kind of marketing that they'd use for pets or for prisoners. It's like, you know, here's, you can keep an eye on them all the time. And that's not very good for human rights. There's also the issues around, you know, what is helping your financial security, or what actually is it making things difficult for you? So, for example, PIN numbers. So people going to get cash from a machine, and maybe they've forgotten how to use the PIN number or whatever. So do they write it down, or do they ask somebody for help? And I need to get some, you know, there's the possibility of kind of exploitation there, or being, you know, whereas before. So these come, like many things. I was saying to somebody this morning that, you know, your strengths can also be your weaknesses and vice versa. But some things that help the majority of people can then be difficult if you don't think about what the processes are for people with dementia. And also there's the idea of having assistive robots, you know, or assistive pets, or like dolls. And one of our researchers actually looked at what people think about these kind of cuddly dolls that you can get. And there's one called Paro, which is a seal. And it's like, well, they didn't think of them as like a seal. They thought of them, or a pet. they thought of it like a doll, you know, like a thing. But they also said, well, yeah, but if we're going to have something like this, which is kind of fun and, you know, we like and cuddly, we'd rather have something that's like a real pet, because you don't get out of the pet store and say, oh, show me your selection of seals, you know. So something like a cat or a dog or something like that, which they're familiar with. That makes sense, really, you know. Although I do have a small seal at home, just a seal of approval, of course, which I hope to get at the end. And there's also this idea around brain training. It's like, oh, brain training. And then the implication, you better train your brain, because otherwise you might get dementia. And so there's this kind of like, oh, what are you obliged to do through society? And there's the idea of successful aging. You know, what is success? How do you don't get a certificate saying, oh, well done, you've aged successfully. You know, so how do you age unsuccessfully? You just kind of age. So this is the kind of spin that, you know, sometimes are put on things about. So if we go back to induct, so we had, and I'll just thank Rosemary Droz and Franz Verhey, who the three of us were the kind of the core team, and Franz did the training, Rosemary led on the research plans. And so we were looking at aspects of technology, and we said, well, it's innovative technology, but it's existing things that we already. So we'll look at things that are already out there, and in distinct, there was a bit more developing new things. So what things make it usable, what things may make it effective, and what things make it difficult to implement in dementia care, or which can help you move on with it. And we actually, with Hannah Christie, is one of the PhD students, we did a study on recommended technology from 5 years ago, which was like the top level technology that was available. And then we looked at that, we said, how much has this been, what out of this, what's still in use? You know, what's really practical, what's actually got into practice? Here's what the recommendations from top level researchers 5 years ago. And so technology for everyday life, technology for meaningful activities, and then healthcare technology. And of course, technology can be electronic, but it can also be, you know, record systems and manuals and guides and things like that. I'm happy to take interruptions and questions at any time, by the way. And I'm planning to finish about 4:30 or slightly before, and then have lots of time for questions or discussion. So the second project looked at social health. So social health has become popular, particularly in interdem, because as somebody said to me, well, the medics understand the idea of social health, you know, what it is, whereas they had trouble, you know, with the kind of medical community about, you know, psychosocial aspects. So social health being capacity to fulfill your potential obligations, ability to manage your life, and being able to participate socially. So this fits in with things like the WHO recommendations around human rights and about being able to participate, being able to be part of a community, being able to be independent and make your own decisions. So, so we've got similar things in the work packages. So for this phase, we were looking more at the environment, and we looked more at robotics, because these seem to be at the fore compared to in induct. And this is a very nicely designed, Rosemary Droz designed the work plan, but you can see how it all comes together. We've got the individual students, the different types of technology, and the cross-cutting factors around practical and social factors to improve technology effectiveness, and again, how you can implement it. So, so again, one slide for me, this, like I said, is Rosemary Droz's design, but for me, you know, one slide sums up how it's all put together and implemented. So, and now, some of you, who's familiar with logic models? Show of hands? Yeah, okay. So, thank you. So one of the nice things about logic models is you can define what you're doing and the aspects of it in a single slide and see how it works together. So here, you've got threats to social health. Here you've got difficulties in inclusion for people with dementia, lack of meaningful activities, reduced quality of life, potentially more crises and difficulties. And then you've got the personal, the disease-related, the social and the physical environment. And then you've got the enabling things here, the solution, things to improve social health. And then what you can measure. So you can see how far it's user-friendly. You can see how it's experienced. You can see the effect on things like stigma. And there's also, and people may be familiar with the re-aim methodology, which is around reach, adoption, implementation, and maintenance. So it's like the various things, aspect of being implemented. And this is kind of an overall view about implementation. So then the benefits, better social health, more inclusive society, better quality of life. Now, one of the things we can do with that is, as I mentioned before, there was a study on, Simone's study on social robots in care homes and what people thought of them. And you can see how well it's, you know, people can use them for meaningful activities. People can participate. They can be experienced as user-friendly. You could evaluate the effectiveness. And, you know, people, then there's a kind of quality of life benefit to people using them. So social robots were quite popular. But they weren't seen as pets, which just happened to be a bit strange. They were just seen as like dolls. Golnaz Atafi, I think, just passed a PhD recently, was looking at acceptance and commitment therapy and helping carers manage their life and how that went down. And it could be helping to better manage their daily life and decrease costs of care. Josephine Tan did a digital photo activity, so people had a range of photos that they could look in a care home, and the photos were not specific to them, but were related to the things they might be familiar with growing up or in their general adult age. And this was used, the digital photo activity was used as a prompt for discussion, having a range of photos that you can then talk about, which is a bit like the principles of cognitive stimulation therapy. So, and here's the logic model for it, which is, so you've got the lack of, oops, I pressed the wrong button. There we go. So the lack of meaningful activities, lack of social interaction, poor social independence. So you have the photo activity, which is here. Photo activity, it was, you could do it with staff or family members. You have conversations around the photos, and then you prove it, evaluate it with quality of life and also discussions with people about what you think. And then they said, oh, the mood's improved, the quality of life feels better. The carers felt they had a better relationship with people, and they were felt more competent. And one of the things family carers have said to us is, you know, when they go and visit somebody in the nursing home or visit somebody at home, is like they want to be able to do things together. And this is where things like cognitive stimulation therapy can be helpful, because it gives you to do things, activities which are fun or which you can do together, and focused around discussion rather than testing what they know. So this is I'll be brief with this, but this is the model of our program involving people with dementia, different stakeholders. And we had, just like you're having the HOMEDEM school here, we had 5 schools and a whole range of master classes. And of course, it did coincide with COVID, because we started in 2020. We had this masterclass planned, 28th of April 2020. I think a lot of us will think about that date and think of COVID, which it was. So we had to cancel that. Then in Germany, we managed to do a hybrid session. I'm not sure how we managed it, but we managed to. So some of us managed to get to Germany. And then we had a mini school in Prague, and then one in Nottingham, and then finally one in Zamora in Spain. So we've got some just slides of this school and how they were done. And some of the feedback were, you know, a nice opportunity to reconnect. And of course, set in the context of COVID, PhD students were able to get together and discuss projects which they'd not been able to do. So, I mean, good for them, because they worked very hard in very difficult circumstances, as a lot of us did. But when you've got a PhD, which is partly based on, you know, secondment in other countries, it just added to the difficulties, but hopefully that helped with their general drive and resilience in the long run. They wanted plenty of time for coffee breaks and to network. And I think that's been one of the things today, is this I've had the feel of plenty of time, certainly plenty of time to present, which I won't be taking, but you know, this sense of being able to interact, and I've had quite a few meetings today. You know, how valuable is that? Yeah. That's the one in Prague. And then finally being able to meet in person mainly. And then the hybrid one in Nottingham, the Institute of Mental Health, which I work. And don't want a few pictures, do you? And so we're having successful hybrid schools now. And of course, wherever we now, we've got a hybrid presentation. And I think my experience now, most lectures and presentations, particularly if they're a wider interest, are done a hybrid. Okay, and we were learning all the way along. And then finally, there's this school in this magnificent setting in Zamora in Spain, which is just fantastic. And there's some lovely pictures of us all. And there's one of the robots there that was used. So again, very positive feedback. So getting on to some of the actual the work that was done. So this is I thought it was amazing, all the different countries people came from. Wei Ki Ko was actually based here. Some of you may remember her. And she did a fantastic amount of work and published an awful lot. And looking at robotic pets under older adults, qualitative study with facilitators, look at barriers to implementation in nursing homes, looked at acceptability in nursing homes for social robotics, and she published a lot and did well with a PhD. Aysan Mahmoudi Aslan she was from Iran and she was based in Spain. And one of the things about the traveling is quite often, you know, people may have their own language, and quite often it obviously helps if they've got good English. But if you take somebody from Iran and then they're working in Spain and they have to learn Spanish as well, I mean, the level of ability and drive and determination you got from people was very impressive when, okay, so you learn Spanish, or you learn Dutch as well as you need to learn these other things as well. So, so you got some excellent people, and also obviously some great results for people moving on to kind of jobs. Did a secondment at VUMC, and some of the secondments we were doing now was actually online. People do an online secondment, you wouldn't see them for a few months, but they. This is the touchscreen photo activity, Josephine Tan, which we talked about, and with a pre and post follow-up, collected data with 25 residents. And so some of the work had to be scaled down because of COVID. Kuba Belak was from, Budak was from Turkey, looking at assistive technology again in social robots in long-term care settings and their impact on communication. So between the various pieces of work, we get a really good understanding of the benefits of social robots, amongst other things. So I'm going to talk in more detail now to give you an idea of a particular project. I picked one that I was involved with. We managed to find a postdoc for Esther. Esther's from the Netherlands. And Esther did secondment with the Rare Dementia Support Group. And Esther was interested in young onset dementia and online peer support. She also did a secondment in the Netherlands as well, which was very familiar to her being Dutch. So some of the things that came out were the unique challenges of young onset dementia, in that it comes at a different stage in life. Sometimes quite often it comes when people are working, maybe they have a young family, a lack of understanding in healthcare professionals, resulting in delayed diagnosis. And dementia services, quite often, diagnosis is delayed. Quite often dementia services are geared around older people with dementia. And, and because there's, because young onset dementia is relatively rare, there's fewer people in any particular community. Now, we're working with Neil Coulson, who's an expert in health psychology and peer support. And so he's looking at mutual support between people with a similar health condition or shared life experience and the potential benefits of that. And actually, excuse me, tea or water, that's a question. Oh. Actually being able to look at that was very useful. There we go. So it's rare. It's harder for people to meet of others for a similar age. Even if they meet some people, it's even harder to try and get people together for groups and things like that. And some of the other things is actually if people have a wheelchair, or there's transport issues, or they live out in the kind of rural areas, it may be hard for them to get to in-person groups anyway, for a whole range of practical reasons. So we thought some of the benefits of online peer support is that you can do it across geographical barriers. There's a wide range of platforms and modes of communication. There's limited research on it, and many in-person groups moved online anyway during the COVID pandemic. So we thought it was, it seemed very timely to study it. So we wanted to understand facilitators and barriers, produce recommendations, and finish it off with best practice guidance. And so Esther was very, very good. And because we've got this overall plan, stakeholder consultations, and there's the systematic review that we did, stakeholder conversation, focus groups on online survey and interview. So we're looking at what we knew about peer support already, understanding from the focus groups how people used it or might use it, the survey looking at actually who did use it or whether they would or would not, and finally the interviews to understand more of the barriers. So all this led to giving a second version of the best practice guidance, and then a final version which was then published. So we wanted to understand what's involved in online peer support, what the options for, and the tips and challenges, how to cope with them. And we did two sets of guidance. One was for people with young onset dementia who were thinking of starting it or when they're participating in groups. And the second was facilitators, because you needed facilitators. Some things for facilitators, well, if somebody's joining the group, you have a meeting prior to that, talk them through what the group is about, how you use it, how you interact, some of the rules about obviously things like courtesy, how to support people, and then whether they might need support after the meeting as well. Or sometimes people put their screen on blank, or they put the sound off, or they just leave the meeting, and they might be upset. They might have some other problem at the time. And of course, people with a group online, it's quite easy for people to leave and then come back in or not. But if they don't come back in, you might worry about them. So, so after extensive work, Esther published the two sets of best practice guidance, which is in one paper. And she brought together the work from the interviews about why would people use online support now, what are they using? There's things like, there's text-based things like Facebook, like WhatsApp, and there was video-based things like, also could be WhatsApp, but also things like Zoom and Teams. And so that's been published, and then I'll show you. So Esther's got quite a few publications. I remember some of the things that my students were slightly shocked by. Harleen Rye on the previous PhD with me in the part of the program said at the beginning, he said, I don't know if I can really go to Indonesia to look at online, the CST app with people with Indonesia, because, how would we do all that? I said, oh, don't worry. So Harleen actually ended up going to Indonesia. The Alzheimer's Society there are fantastic, and published a paper on the Indonesian community's views on CST. And with Esther, what we found was that there was very little research on peer support for people with dementia. I mean, almost nothing published. So we decided to look at three related disorders: Parkinson's, multiple sclerosis, and ALS. And so she ended up doing 3 reviews because there was enough on each to distinguish them, and then her best practice guidance development. And so that's Esther's email, and so she's done well with getting her. They had a talk this morning on why to publish from your PhD, so Esther's done well with that. So a little bit about our secondments, and you can see some of them were based online, and some of them were based in person. And now, of course, there's many more things you can do online, but you can also miss out on the experience of the community, the kind of corridor culture. And the ESRs collaborated quite a lot. And these lines, it looks like some kind of physical or chemical thing, doesn't it? But it's actually about how ESRs collaborated with each other. And you could see number 6 and 7, lots of people they collaborated with. And the more they collaborated with, quite often the more papers they got as well, because it's like they're helping out with this study or that study. And there were quite a few papers on the actual collaboration process. You can see people's names, people who are involved named there. And we had some really good meetings with the European Working Group of People with Dementia, and talk about how to adapt it online. And what we needed to do was we had shorter meetings, and we gave them some notes in advance of what it was going to be about, so people, if they wanted to, they could prepare. And so the ESRs, rather than having a big meeting with lots of ESRs and lots of the group, actually we'd have shorter meetings. And there's, I think, Helen is there. There we go. Brilliant, thank you. And and so we had smaller meetings, and it was checked and moderated by ESRs with support of Alzheimer Europe. Anna and Diana from Alzheimer Europe, really good. And most people actually like using Zoom and express themselves and could have a natural conversation. And the ESRs learned a lot about, being able to explain things better, particularly in advance, and sometimes about how they design their questions. And the sessions needed to be moderated to allow people to focus on the questions and also be able to express themselves. And we've done well with the Alzheimer Europe conference with the most influential tweeter. We don't talk about it's X now, isn't it? We don't talk about the most influential Xer. And we also had a special symposium in October 2022. Lastly, for a few minutes, I'll talk about the best practice recommendations. If you put into Google Dementia Induct, you'll come out with our site, and you can go to the best practice recommendations, and it's quite easy to navigate. And I'll give Rosemary Droves a credit for this. She's in the Netherlands, and there's a guide to how to navigate it. And also you can choose what category, what kind of information do you want, and where are you coming from? So if you're a care provider or policymaker, you can choose the themes, and you can use that to find your way around. Now, what we've done is we've taken the guidance from Distinct and we've merged it. So we've got one set of evolving best practice guidance. And so here you can see particular things related to some of the projects. So you click on the various areas and navigate, and you can also read more. So think about empowerment projects and how to avoid stereotypes with those, which is good. How OTs might be able to help people with dementia with everyday technologies. Technological problems should be solved before looking at the effectiveness. I mean, that makes a lot of sense, doesn't it? But suggests that not always done. And this was about exergaming, and exergaming was a way of people in care homes using a gaming machine that allowed them to have exercise as well. And so one of the things there was make sure it's not just reliant on one staff member being there to help people. You need to train several people, because then they collaborate and they work together. It's kind of quite an obvious thing in a way, but we kind of developed them from our work. And then finally, we've got the scientific relevance about easy to use technology, how to apply them clinically, and also benefits for society and social inclusion. And finally, thank you for your attention. Thank you. So I can, yeah. I'm happy to do questions and things. I'll shut it down.
I think so, yeah. If
So I'm keen on questions and also points.
and what?
Points, you know, people want to make a point about
Of
something.
course, yeah, sure. Okay, so thanks very much, Martin. That was really interesting. Very interesting, I thought, in terms of, you know, various practical ways in which technology might or might not help people with dementia and their cares, but also then for all the aspiring researchers in front of me, very interesting in terms of the process of how Marie Curie awards work. I thought that was fascinating. So floor is yours, and I'll try to see who's putting up their hand or wants to make a comment or a question for Martin. Fiona.
Thanks, Martin, for a very comprehensive, interesting presentation. Following on from the earlier session, Helen was, gave a very good account of how she uses technology in her everyday life, and Brendan was talking about the kind of home care landscape. How do you think and it's rapidly developing, as you say, you looked at 5 years before, and who knows what's going to be available in 5 years' time. But, what's your sense of the ways in which technology might replace specific aspects of home care? At the break, you were talking with colleagues about these very brief check-in calls. Is that the kind of thing maybe that's going to be done by some sort of technology?
Well, I think the first thing about technology, it has to work and be designed around what people want and find useful, and it has to be empowering. And we did a study on, a few years ago, we did a study with people with dementia, family carers, about what would be useful in the event of a crisis and what would be useful to help prevent a crisis, and what came back to us was actually they were quite keen on technology and aids at home, whether it's smoke alarms or communication or whatever. And they were less keen on multiple people coming and visiting them and checking on them, when they have a home care and they get a different one each day, they don't know who's turning up. There's a privacy issue here about who you are comfortable with in your home. And I was talking to Marie about some of the studies, Madeleine Devote, where what's the experience of people with dementia of certain things, and she talked about where they somebody would, so this is for the researchers, somebody would just come along and wash their feet without talking to them or doing anything, and it's like it's a strange experience for somebody that you're not familiar with. And of course also for home carers or family carers, sometimes there's difficult things to do anyway, which are quite personal, and you feel maybe you shouldn't be helping your mum or your dad with this particular thing, but you need to because that's what's needed. So I don't think we should see technology as a substitute for humans. I'm very clear about that, and it's interesting. I guess with things like the robotic seal that people, they thought it was quite nice, it was quite comforting, but they didn't see it as a seal, they saw it as a doll. It's kind of a doll, and people in all age, some people in all ages quite like that kind of thing, and things to cuddle and things. So how's technology going to evolve? Well, I suppose one of the pluses is having the ability to communicate with people quite easily. So you could have an Alexa device or a touchscreen device that somebody can ring you on, and then, you know, just like any call, you can answer it or, you know, maybe not answer it. And people can see how you are and how you're getting on. And of course, you know, you can have a family member in another country, just have a chat with you. How's everything going? Have you got enough food in the fridge? How's everything? And so some of these can be, you know, friendly and supportive, which we couldn't really do so much before technology. And I think in care homes also, being able to speak to family members online. I don't think there's been too much of necessarily thinking they're a different person or thought they're actually there for their caregiver. So, and as you picked up, I'm less keen on the kind of things which are impersonal and intrude on your privacy or human rights. So I think some of the basics, like sometimes door alarms or smoke alarms, you know, are likely to stay because they should, you know, and will develop along kind of communication devices and things like that. In terms of whether, you know, the kind of remote check is going to replace the daily call, I don't know. I guess there's things about, well, you know, there's things in relation to, well, what do they need? You know, is it their meds? Is it just to check that they're safe? Is it just to chat with them and see that they're, you know, got food in the fridge or what? And, some people might like a daily call with the same person. Other people might find it a bit intrusive. They'd rather just speak to somebody on the phone or be left to get on with it. So yeah, is that okay?
Yeah. Well, that's great. Thank you, Martin. Wonderful to hear that.
Thank you.
Good morning, Helen. Everything okay?
Yeah, exactly. Is everything okay, Helen? Yeah.
Everything okay, Helen? Have you any
Yeah,
plans
yeah.
today? You know,
Yeah.
where are you going? Lunchtime, you know, Helen, what have you prepared for lunch today? Do you have any
Yeah.
lunch? You know, there's the technology is already there to ask us, you
Yeah.
know, and I suppose I hadn't really thought about somebody calling me to ask me these things. I quite enjoy just having been asked by my Alexa or whoever. You know,
Yeah,
just,
yeah,
you know,
yeah.
it's very interesting because, you know, I love somebody visit, lots of people visit me, but I had never really thought too much about the fact that I have somebody that asks me every day, or whatever questions I want to put on, or be asked with the reminders, you know, the reminders like every night, if you're taking your medicine, if you lock the door, you know, if you close the garage, you know, if you, all those things, a whole list of all those things that, and they're also in paper format everywhere, all over the house. So just in case, and I hadn't really thought, to be honest with you, until you mentioned it, that which would I prefer, to have all these strangers coming into the house every day, or to just listen to something to remind me?
You know, it could be a mix.
Could, but it could be very cost effective
yeah,
as well. And
there's also like what works for you and how that might change over time. I remember when I was working in a memory service, and I saw a family carer with somebody, and they said, "Oh, it's terrible. They use Post-its for everything." I said, "Well, so do I. Look, I've got a whole, you know, when I was using them a lot then, that people we've always, you know, people do use practical memory things and have done for many years, whether it's a diary or Post-its or things like that. Now, of course, it's, you know, email or messages on your phone, and so it's okay to use memory aids and things. Kind of, why not? Carmen, thank you.
Yeah, I'm just thinking about a few weeks ago or a month ago, I was in the Netherlands looking at the green care concepts and the freedom that technology has given them, because it's a working farm
Yes.
in the middle of the country, just like here, and nobody has thought about it really here yet. If there is a care home away from a village, it's locked down, they don't get out the door. Whereas there, they have technology and they're free to go.
Yeah.
And then if they want to walk, and if they're known that they walk for 2 hours,
Yeah.
and then somebody will be monitoring and they'll go and collect them and bring them back. I thought this was fascinating. And everybody was at different levels. So the way they could use the technology to suit everybody, and you didn't take any notice. So I think it's brought a whole new level here. There's huge opportunities for people to go and look at, and we have nothing. We're still very institutionalized here in Ireland.
yeah.
So but yeah, because we want to stay rural and for farmers to stay in their own community.
I think that's great. It's fantastic. And actually, as I mentioned to some of you, that we're leading a project with the WHO on good practice and human rights in dementia care around the world, and care farms will be one of the examples. We actually did an interview with somebody who was a manager of a care farm, and we were talking about these things and what, have you empowerment and a whole range of things like that. And I said, well, well, how about on the farm? And he said, well, when it's time to milk the cows, people help, because they don't, it's a farm and people have to contribute what they can. So, which is a great bit of empowerment, but it's also kind of responsibility as well. And we, I'm editor of the journal Aging and Mental Health, and I remember a paper we had from Uganda about, care for people with dementia. It was a qualitative study. It was very interesting, and it was saying, well, this thing is saying is that when the harvest is coming in, everybody helps in whatever way they can, and including if you've got dementia, you contribute, you do what you can, and then that's kind of part of your human right is to contribute. And Ethne, thanks. Thank you.
Thank you. I'm a researcher in the University of Nottingham, but I was going to speak more from lived experience. I'm in the Dementia Carers Campaign Network, which Carmel and Helen be familiar with. And yeah, my dad was a farmer and had dementia. That was a massive issue for us, especially when he was still quite well. He still wanted to farm, go out on the farmland. Yeah. And we did look at all these different technologies about, that we could monitor his location, which he was comfortable with. I know some people wouldn't like that, but he was fine with that. But we found that it just didn't work in rural Ireland, because all of the technology is based on maybe the tracking only works within a certain radius, or where there's no signal, or else it doesn't give you a specific location, it gives you a very broad location. What was suggested to me in retrospect was we should have used a drone, which might be a bit sinister.
Sure.
But then maybe my dad could have used a drone himself to count the sheep, rather than going out somewhere remote to count them. But it is a massive issue, but all of the technology options we tried didn't work, but maybe there are better ones, or
well, I hadn't thought of a drone, but I can imagine with an infrared camera, it would pick up, it's what they use sometimes, isn't it, when they're looking for people who are lost in the wilderness or something like that.
It's used to bring defibrillators or medical equipment to people who are stranded, in remote
exactly,
areas, or first responders use it to find people. So they are using it more in a medical way rather than just.
And I guess that in any aspect of life, there are risks. And it's about what can you do to reduce those risks to a reasonable level, and which is, working with the person. But like you said, you tried various things, and
we ended up going with a very low tech option in the end, which was calling his border collie and then following him back to where my dad was. So that's how we'd figure out the location.
We had a border collie as well.
Yeah,
they'd be good at that.
Yeah, well, he was running the show. He was the brain power.
Okay, right, yeah. Border collie based care. Yeah, thank you.
Over here, Marie.
Hi, in Ireland we have memory technology resource rooms. So it's where people with dementia can go and meet an OT and see what's on offer. But the biggest issue that I've seen down to the years is getting buy-in from people to invest in the technology. What would you have to say to people like that?
Well, I guess there's two aspects of buy-in is kind of purchasing it, but it's also using it. I guess the first step is, dementia is stigmatized. So the idea of a diagnosis of dementia is tricky, and also with interdem they talk about timely diagnosis. Diagnosis at the right time for people. And so people don't like things that make them feel a bit less independent and a bit less empowered. So, and from the OT point of view, remember, I work with an OT on a big research project on dementia, and she was talking to me, and she said her mother had needed a stick, and for 4 years she'd been saying, her mother didn't have dementia. She'd been saying to her mum, "Oh, Mum, why don't you get a stick that's really helpful?" And after 4 years, the mum said, "You know, I've had an idea. I think I'll get a stick. It might help me with my walking." And so there's something, I guess, about the timeliness, and there's a lot about, I guess, dignity and respect. I like telling this story because I've told it already on this trip, but my brother-in-law and sister were talking to my mum and dad when my mum and dad were in their 80s, and he said, "You know, Bob," he said, "if something happens to one of you, the other one's welcome to come and live with us." And my dad said, "Yes, and the same to you." So, you know, it's like we're not trying to switch round roles. So you've got, you know, children who are now trying to parent their parents. They're still your parents. So it's a part of it is like thinking, what might be helpful? Is any of these things that would find that it would work for you? I mean, also my story about my dad with the computer, the very basic, it's like, no, he was fine with what he had. And then, you know, as experts, you know, you can prescribe some medication for people. If they're not on board with it, they're not going to take it. They might accept it. And also there's people who will come to the clinic because they've got a lot of pressure from people. They don't want to hear the diagnosis and they don't want to come back again, but they said they'd come along because that's what they said they do, under a lot of pressure, and they want to do their own thing again. So it's a difficult balance, and I think it starts off with, you know, respect and dignity, and think, well, is there anything you might possibly consider? And of course, if they don't want it, what are the consequences? You know, how high is the risk level? Is it, you know, it's probably higher than it would be, but is it tolerable? Is it, you know, are they gonna, I mean, if you've got somebody who, for example, is, you know, careless with matches and is always smoking, and then, you know, if the risk is, well, they might burn their house down, I mean, that's a really, really big risk, you know, really big safety thing. If somebody wanders out every so often to the shops and comes back, and that's what they do, and people are worried about where they are, but they're always at the shops, they're always walking the dog or the border collie or whatever. But, you know, so it's different kind of risks, and you know, people without dementia also take risks in life, and it's like, well, what's manageable? Is that helpful? Okay, thanks.
Marie, you had a question? Then.
My question is also about the memory technology resource rooms, which I think is really a fantastic initiative that's developed and being rolled out across the country. And I suppose one of the real benefits of it is that the technology is developing so fast, and one of the positives is the OT's been able to kind of keep up to date or abreast of all the kind of developments and the research that's going on. And I just wondered, is that model available in other countries, like in the UK or Spain or the Netherlands, that your projects took part in, or is that something that's quite unique to Ireland?
I don't know. It does sound very innovative, and I suppose my question, would be if you're using them, and if there's something about getting people to take on things, is whether or not, you know, how about the PPI aspect? You know, have you taken people with dementia and family carers who don't need the technology around and say, oh, what do you think of this? How's this presented? You know, is there something we could do to make it more acceptable? You know, so you're not actually trying to pitch it to them, but you're saying, well, how does this, you know, because I guess from the professional point of view, it's great, and it's got a lot of obvious things that you'd really like to use. But it would be interesting to, just like we consulted people on what they thought of a robotic seal, you know, and it's like, oh, that's, you know, we might think, oh, that's nice and cuddly, and they think, well, I'd rather have a dog or a cat, something that you're used to having as a pet rather than, it's a small thing, but it would be interesting to know. But also, if you did some consultations with people with dementia and family carers about them, and then you could report on that, and then the Alzheimer's Society in Ireland could say, oh, this is the feedback we've had, and then you could have maybe more of a strong support for it. So I'm not challenging them, just saying that it's hard to know what it's like from other perspectives.
Just kind of say, can I just add something to that? It's a medical model.
Yeah.
And if somebody said to me, if my son said to me, Mum, I think this would be good for you, I think I would buy into it a lot quicker than having that medical diagnosis and then this is more medical where I'm looking for something more social. You know, if we look at more of a social model when it's being presented to us, as opposed to we look at somebody else within the health service telling you, you know, this would be good for you.
Yeah.
Honestly, I think it's much harder for us because then you're really feeling like you expressed earlier, you're feeling this thing, something's taken away from me. Now I have to add this new thing to the house. You know, where when I was presented with my husband passed away and I had to get cameras, you know, so so then alarms and all these systems that you don't have when you're living with somebody. And then, but they were just from family.
Yeah.
I think honestly, I think from a medical perspective, somebody suggested in the mail, I thought, oh God, not again.
I mean, I guess one of the things is that people come from different backgrounds and they have actually some of the characteristics, like being, you know, wanting to be independent, being feisty and things like that. These are really good things to have. And sometimes that does clash with the medical model when you, so it needs to be more participative. You know, it's like weighing things up, you know, well, out of these various things, is there anything that, you know, here's what they are. And like you said, sometimes, because I mean, sometimes family can be helpful because they support you and they say, well, I think that would really help. But other times, it's the reverse, is that you've got, you know, family are actually putting a bit of pressure on and trying to, having a sense that they might have to make decisions for you. And it's like, well, so it's a balance and it depends on the situation, I think. But I agree with you about the medical model, because even sometimes the term person-centered care, which is a good term, we know it means good things, it also sometimes you get to then somebody's in the middle of their care and then everybody's acting on them in some way, whereas actually it should be more participative, like, you know, like other aspects of health and medicine is. It's a discussion, it's a negotiation. If people don't want to do it, they won't do it. So you need to, you know, think about it, negotiate, think about what's really important. Thank you.
I suppose I'm kind of struck as, you know, in economics, I sometimes think about, you know, what a wonder the market system is. You want to go and buy a car tomorrow and you've got all these thoughts in your head, all these characteristics that you're kind of interested in or possibly willing to trade off. And at least, you know, in a place like Galway, you know, you've probably easily come across 100 different models of cars, and, you know, you've got your willingness to pay and your budget and so on. And what we like about the market is that, you know, all going well, you with your preferences and the market on the suppliers on the other side will come to some, you know, mutually beneficial trade. So then when you think about the different issues that arise for people, say, with something like dementia and all the different possible wants that they might have, and you're relying probably not on the market, but more on an administrative side of things, your question is, can you get that kind of flexibility or variation or heterogeneity that you'd see in a private market? Can you get that in terms of the provision of support so that people are getting what they want when they want it? You know, and I suppose medical model might say, look, we're giving you this, take it or not. Whereas, like, you know, when you think about all the, I mean, I don't know any of you here, or most of you, but like, we're all such different people. You just put 20 or 30 people into a room. They're all different. And it's those differences that matter when it comes to, at any stage of life, but obviously when it comes to caring for people with dementia. Anyway, rambling.
Thank you. So, I mean, I agree with that. I also think sometimes what I don't want is necessarily an awful lot of choice. It's like, oh, it's how do you figure out what you need out of these things? And one of my researchers, for some reason, still uses an example of like when I wanted to buy a new coat, I had all these things that I was looking for, which I couldn't find. So I bought the next best thing I could in terms of, I bought one I didn't like all that much, but at least it covered the other things I wanted to do mostly. I think a lot of life is like that. It's like, I'd like something like this, but it's not out there. So you get something that's imperfect, but it kind of does the job. And I think that sometimes dementia care is like that, that you know, this might be the ideal scenario, but what can you make the best of in terms of what's available locally and what you have? Recognizing that not everything is going to be accessible.
Other comments or questions? Yes? Nancy behind you.
Hi.
Oh.
I'm just wondering, I suppose, between the earlier talk that we had and home help, be it HSC or private agencies or whatever the case happens to be, I suppose from my feeling, I find that home help tends to be, current model anyway, is very, we've used the word prescriptive a lot today. It's very task-based and, you know, the shower, the getting dressed and those kind of tasks. To me, it seems anything outside of that in terms of state actions is very much based on family and or the person and what they can do, be it financial or whatever way it works. But what would your feeling be on more state involvement in more research or more use of technology when it comes to home help, especially with dementia?
Well, I'm glad you asked that, because home help as a service has been very understudied. There's very little research on it, which is terrible. You know, there's not much research in care homes and nursing homes, but there's quite a bit overall. There's very, very little on home care and home help. And there needs to be much more, I think, work on that. And this in terms of also home help training and what home help knowledge of dementia is and awareness. And I think more research would also help us value home help more. So I think I agree with you that there's more research needed on home help and technology and what they can use. And in some ways, you know, if that helped empower people with dementia, but also help empower home helps, feeling that there was, you know, they had more skills they could use and more ways of helping, and they were learning more, that would be good. And so, you know, to the researchers here, I think home help particularly, but also supported housing, is again very understudied, widely practiced, very under-researched. Thank you.
Talk about the education of parents. I'm just wondering, again, I just feel, you know, if the agencies take on a carer, they have to have all these levels. And I'm just wondering, at the very basic, I would have thought would be that the person has empathy and understanding and care. I don't agree with all this BTEC level 5s. That's, I mean, I just want somebody who I connect with, that we connect with as a family when we're caring. And that was another thing in the Netherlands. In the farms, they'd crack you if anyone had gone in, because health and safety, we're just gone overboard here. Like, you went in there, it was like a normal home. It would have been even worse than my own. But with a mess. You think, I was thinking about solid fuel stoves, and we go out the window here if we saw something like that. And and they trained the staff as they went along. They didn't have to have a level of education coming in the older person and this and that. And I just feel we're gone a bit off the Richter scale on that. And they were excluding a lot of people who are genuinely want to be in the profession. And there's lots, like there's literacy issues, there's huge issues. And I know myself, several people who would love to work in the industry, but they're never, ever going to take those level, whatever, no matter how much you try to persuade them, it's not going to happen.
Well, the other thing is sometimes it puts people off, you know, that think, well, I don't mind learning in the job, you know, having training in the job, but it's a bit daunting to have to get all these things before I even start. And you know, because people quite often they want experience of the job to see if actually does it suit them, you know. So yeah, we don't want to put people off by making it so so daunting. And if they've not had a very strong educational background, you know, quite often they can, you know, they can learn later in life and do well, but they need, you know, different support according to who they are. So, yeah.
Again, Carmel, that's prescriptive. That's a requirement of the HSE.
And that's what we need.
Yeah, and I think if I can give any assurances, because both myself and my colleague here work in the private agency sector.
Yeah.
I haven't always. I've, as ladies will know, I'm a massive advocate for people with dementia, having lost both of my own parents to dementia. But what I've seen after my year working with private agency is that the HSE prescribe, dictate everything. And when we interview somebody, it's can they do the job? Will they meet the needs of the person? Will there be a connection? So from our perspective, that's all I can say. But and again, I've had people come into interview and they said, I have no formal education. And to even mention the word training to them is hard. And we literally hold their hand the whole way through. But like the requirement of the service level agreement is that all staff going out into the community delivering home care as per the HSE must have the QQI level 5 in care skills and care of the elderly. That's an agreement, that's their writing, you can't break that. And from what I can see, it doesn't put a massive amount of people off. They're applying or lifting the phone, and I think once they know the support is there. So I would say to anybody who's even thinking of, okay, is this for me, just to make the call, to lift the phone and make the call, because the support is now there in the offices. But I think, as I said to Fiona earlier, going back to the home care, you know, conversation earlier, home care is a separate service to private care. There are things you can deliver under the private care service that you cannot deliver under the home care support service that are detrimental to people who are living at home with dementia. You can't feed a person with dementia under our statutory home care service. Like that's a basic human right. You can't put a cup to their lips without it being agreed and signed off. So, you know, we talk about, you know, recruitment, and yes, it's a massive issue. I deal with it day in, day out. It's a massive issue. But people who apply to become caregivers are applying because it is a vocation for the majority of them. What turns them off is us not being able to fulfill a full working day for them in an area, because we have a half-hour call here or we have a 45-minute call here. Block hours, as they're known in the trade, is where you might have 2 hours in a block. They're more attractive to caregivers. We have to look at why intensive home care packages are not being shared equally across the country. They are not being delivered in CHO2. And so there's so much more work to do on home care delivery and what it would look like and what it should look like. But I think if you want to get the insight into it, you're going to have to engage with agencies like ours, because we're living it every day. And I suppose I just want to throw that out there to you as well, you know, because with the best will in the world, you know, we can sit here and talk around in a circle. I met Helen back in 2012, and so little has changed in the dementia space, except that I've lost 2 parents to it. So it's very frustrating, you know, and it is pieces like what you're doing in Connemara, Carmel, that make the difference. It's the community supports, it's the community activists that will lead the charge and lead the change in terms of supporting people with dementia in our communities.
Can I just add to that, that I think in 13 years, I think we have made changes. People are talking about it. People are talking about it. People are recognizing it. And very soon I'll have the robot doing the work for me.
Right. Thank you.
Brendan, yeah, sorry.
Yeah, I've got a question without a question mark, maybe, but touching a little bit on what the previous people have said, and you know, risk is important. Box ticking. The person, if my remuneration is based upon me ticking boxes, I'm going to tick a box, and it seems, at least in Ireland, from a home care perspective, that's one of the reasons technology is always outside of the home care package, because it's not essentially included in a regulatory sense. And at the moment, we're talking about really regulating the system like we do care homes. So currently, home support here is not regulated like you would with nursing homes. And as an economist, and Brendan will know this, there's pros to regulation, but there's a lot of negatives to regulation as well. And in terms of how technology can be used in a safe way, but also in a way that the individual wants to use it, or the type of technology they want to use. Is there any evidence kind of from the literature on some of the negative implications of being too strict in the regulations that you impose when it comes to the type of services or technologies that can be provided to people?
Okay. Well, I guess some of the concern sometimes is, certainly in the UK, which I think has similar issues, is that there's some kind of scandal and there's a knee-jerk reaction, then a new policy comes in, and there's a trend towards adding red tape and regulations, and at some point, hopefully, they get trimmed down. I mean, I guess one of the things is about measuring the benefits, you know. So in terms of how you measure things, you can measure the structure of things. You can look at, you know, how many people you have and whether you've got the right number of people for service. You can look at the process in terms of, you know, what they're doing and how they're doing things. You can look at the outputs, which is things like box ticking and how many visits they've done and things like that. Or you can look at the outcomes, which is like things like how long are people managing to stay at home? You know, how long are people managing to stay at home and stay independent? And we tend to measure what's easy to measure rather than what's harder to measure but important. So I think, I mean, you might say, well, what would people like out of home care? Well, you'd like to support the person, you'd like them to be safe with that person, and you'd like to help people stay independent and be empowered for longer. And a lot of people get, like you said, get fed up with box ticking. What's it actually doing? And how much time is it taking away from the important things in care, like, you know, conversation, you know, how are you today? Did you enjoy your dinner? Or a range of things like that. So, can I answer it in that way? Thanks.
Any last comments or questions? Yeah.
Online, it is.
Where?
Hello? Online, hello? As we usually say, is there anybody out there?
That's a line from a Pink Floyd song.
It is. Yeah, it is. And also from a Duran Duran song as well, I think. Yeah.
Who?
Is there any Duran Duran?
Come on, don't lower the tone of the conversation by mentioning Duran Duran in the same.
Well, which was it from? Wish You Were Here. The Pink Floyd song.
No, I think it's Comfortably Numb.
Okay.
I think so, but I'm not sure.
Well, I don't know if anyone's going to challenge you on that, but maybe not. Thank you.
The talk ended with a dispute over which particular Pixar song.
Oh, there we go. Somebody's going to help us with that last point. Hello?
I win the prize.
Comfortably.
Okay, so if there's only one thing that you learned from today, and which is sometime later today, look on YouTube for a version of Comfortably Numb by David Gilmour at a concert somewhere in South America. I don't think it's, and there's a young woman there, and if you have ever seen a more emotional embrace of a song, I doubt it. So anyway.
There's also a line from Wish You Were Here, which I like, with, would you exchange a bit part in a war for a lead role in a cage? And it's like, you know, in the sense of being able to be active in life and have, you know, participate. So I hope you're not all feeling comfortably numb after this talk, but thank you very much. It's